We have some time for clarifications. Dr. Tan Wu Meng.
Thank you, Mr. Chairman. By way of clarifications, I have one observation and one question. First, regarding the Senior Minister of State, Dr. Janil's observation that relooking healthcare needs to be through the lens of longer-term issues in a COVID world and looking at the larger social ecosystem. I agree with this approach. It is essential in our approach to society and healthcare. I have a follow-up question for the Senior Minister of State, Dr. Koh, regarding the earlier point in my speech on the approach to outsourcing hospital cleaners and hospital attendants. I don't expect an immediate resolution to this question, but I would urge a longer-term rethink once the COVID crisis is over. After all, COVID has raised many questions of countries around the world. If its supply chains, countries are looking at just-in-time as compared to just-in-case. And may I suggest that on issues of workforce, we also may want to look at economies of efficiency, but juxtaposing this and considering as well the resilience of solidarity across the entire healthcare team. And I hope MOH will consider this as part of a longer-term review for the COVID world and what comes next. Thank you.
Mr. Chairman, I thank Dr. Tan for his clarification. I will agree with him that actually, as needs evolve over time, and certainly COVID is a very challenging time for us to actually also take stock post-COVID, what kind of healthcare model we have, and in that case, to build resilience within maybe certain critical parts of our healthcare system, do we need to review the current structure in which we engage with outsourcing of staff? So I don't think we're ideological here, but we will take an open-minded approach to review the needs and maybe talk to our healthcare institutions as well to see if during this period whether they have made useful insights and observations to warrant a change in current approach. But I must caution also that in insourcing back certain levels of staff within the system, we need to make sure that there is still a meaningful career progression prospects for them as well. Because if there are a small number for which there is actually a little career progression, we need to also bear that in mind to balance out the needs of the organization versus aspirations of the person. Thank you.
Dr. Lim Wee Kiat.
Thank you, Chairman. I have two clarifications. First, for PASEC, regarding the vaccination program, I'm happy to hear that there are a huge percentage of our seniors have been vaccinated for flu as well as for pneumococcal. But the issue now is, of course, the outreach to the rest. There's currently now no specific outreach program to reach out to seniors that have not been vaccinated. So I hope the MOH can review and then take a look. When I take a look at the Health Hub apps itself, there is immunization charge based on age, but the age stopped at 26 years old. Beyond that, there's nothing. So can you all take a look at it to see how to expand that further? My second clarifications go to SMS, Janil. I would like to ask the SMS on a hypothetical question about if COVID-19 outbreak were to happen in Singapore, in the sense that what happens in November 2019. Could our current system or our NCID have picked up the unusual sort of presentation of pneumonias, and could we have the capability to diagnose such a novel virus? Looking back, do we have the ability to do so? Thank you.
I thank the member for the clarification question. Thank you for highlighting the issue with regards to the health age cutoff. We are indeed still developing the platform and we will be adding more information. So I'll bring this back and then we'll develop it further. In response to the query on the outreach on vaccination, especially to the seniors, actually HPB has recently launched a public campaign, public education campaign to encourage eligible individuals to get vaccinated and getting them to increase awareness, because the key thing about vaccination is getting them to be aware of it. So we did try to roll out a public education campaign, and this is something that I think can build on. The other thing is also working with the GPs, with the doctors, to actually get them to routinely advise their patients on vaccination needs, especially every time they come to visit. We would ask them to actually inform their patients so that this will also increase awareness and the interest and uptake for vaccination.
Mr. Leong Man Wai. Please, SMS Janil.
Thank you, Mr. Chairman. If I understand the member's question correctly, is on if an outbreak occurred now, no. With the capability we had then or the capability we had now? So if we had the capability that we had in October 2019, would we have picked up a COVID-19 outbreak in October 2019? The short answer is yes. We pick up outbreaks of disease on a regular basis, and our level of paranoia, anxiety, concern about this increased after SARS, as a result of which clinical teams across our healthcare network have to report any number of either confirmed or suspected infectious diseases, and we have surveillance systems. So the real answer is not really whether we would have picked it up, but how quickly would we have picked it up, and how quickly would we have responded and put in place many of these strategies that we now see as normal for containing a disease outbreak, whether it's the testing, the tracing, the speed of that, the ability to quarantine individuals, the ability to do the sequencing and stand-up therapeutics. So certainly our capabilities have improved and increased quite significantly since the first outbreak. So the short answer to the member's questions is yes, but we can do it much better today. One of the reasons why we can do it much better today is because this isn't SARS, and we've learned the lessons from SARS, we've learned the lessons from COVID-19, and we have to prepare that disease X, the next pandemic and the next crisis, will be like neither. And we need that institutional agility and institutional capability to deal with the unknown, which is one of the more difficult things that we have to do. I hope that answers the member's question.
Mr. Leong Man Wai, please.
Yeah. Thank you, Chairman. I have two clarifications. One is, I think the ministers and the SMSs did not answer my query on how the public health services are being priced. Whether it's based on marginal cost or average cost. Maybe I add a few more information on that, or specifically about whether it's based on amortization of assets, land cost, rental cost, all this, I hope to be clarified. Okay. Second question is on the MediShield life insurance scheme. I'm actually still very puzzled why our healthcare insurance schemes are left open-ended. Because as one gets older, as Singaporeans get older, actually they will find it more and more unaffordable. I have spoken in my speech also that when the Singaporeans get older, like 80 years old or 90 years old, the premium will become very high. For example, under two scenarios, when you keep the premium...
Mr. Leong, can we not have a speech? I just ask your clarifications born out of the responses of the POHs. So okay. Please get to the point of your clarification.
Okay, then I would like to ask for clarifications that the MediShield Life scheme indeed, is unaffordable, as one gets older, and there is a drain on the CPF resources on the Singaporean, and that is a very high number up to $110,000, for a family. So those are the questions I'd like further clarification, because these are very important. It has to be answered. Thank you.
Mr. Chairman, I will attempt to explain the MediShield Life premium issue, which I've actually done an extensive explanation when I gave an update to this House late last year. And I think the answer still applies. Mr. Leong should check the Hansard. I think his point that the MediShield Life premium is unaffordable the older the Singaporean gets, is not correct. Because if he checked my Hansard, he will have understood the fact that actually for the pioneer generation, who are the oldest Singaporeans in Singapore, they get MediSave top-ups to account for premiums that they need. And in fact, for many of the oldest in the pioneer generation, they get virtually free MediShield Life because they virtually pay no premium at all. So I don't think he understood what was said in the House last year, and I urge him to read my speech all over again in Hansard.
Ms. Carrie Tan.
Thank you, Chairman. My question is related to mental health. And thank you, SMS, Dr. Janil, for sharing with us about the tremendous progress made in the mental health master plan, and to know that there's so much more infrastructure and community care facilities set up, and that we're already ahead of targets. But my question really is that whether MOH has a view, or is it currently embarking on any kind of study or upstream prevention campaigns, right? In the likes of when we identified diabetes to be a big healthcare crisis for Singapore, then we went on a very national campaign, and we looked into reducing sugar and salt in our food, in the hawker centre, etc. And I remember when I was a child in primary school, I was also in the Trim and Fit Tough Club
Ms.
to
Tan,
address
if
obesity.
you could kindly ask your clarification.
So my question is, does MOH has a view or intention to study how we can embark on a prevention strategy to avoid this continuing trend of high incidence of mental health or mental illness amongst our population in the long run? Thank you.
Mr. Chairman, the answer is yes. It's not just MOH that is interested in this. This is an area where the academics and the professionals working with people with mental health issues are very interested in looking at. This is not going to be an area that we can have complete prevention, and we also have to research into areas about how we can help people cope and mitigate the mental health issues that they come across. It's not going to be easy to pinpoint a single factor, just like diabetes. While we can concentrate our efforts on the sugar or weight loss activity, we will have a variety of things to direct attention and the efforts of the individual and the family. But the reality is that it's a wide space with many different causes and many different paths through it, and it will be something that requires effort from a multidisciplinary team and indeed the whole of society. But the short answer is yes, we are very much interested in this effort.
Mr. Gerald Yam. Oh, Minister, my apologies, I didn't see.
Thank you, Mr. Chairman. Let me just add on to what SMS Janil has explained. I think mental wellness is quite a complex issue, and very often it is not just a medical issue, and therefore very often when we want to address challenges of mental well-being, it will have to go beyond the Ministry of Health. And that is why we are forming a multi-agency platform to allow the various agencies, including Ministry of Social and Family, including even the manpower, to look at the workplace mental well-being, and including Ministry of Education to start from young. So it's a multi-pronged approach, and it requires a whole of society involvement in this, particularly in preventive health, because preventive mental health, because it requires a lot of support in the community to work with us, work with various ministries, various agencies, so that together we can better address these challenges of mental well-being and help our Singaporeans, particularly the young, to be better prepared for the challenges that they're going to see, so that we can strengthen their resilience against mental challenges.
Yes, Mr. Giam.
So I have some clarifications for SMS Core. First, can I confirm the ministry's definition of PCHI is based on family members living under the same roof? Secondly, what is the ministry's main concern about allowing greater use of MediSave in polyclinics, SOCs, and restructured hospitals? I know MOH is worried about premature depletion of their MediSave accounts, but however, MediSave can only be used for medically necessary treatments, and the risk of doctors in these public institutions over-treating is minimal, and patients there also have little discretion to demand unnecessary treatment. On the flip side, patients do retain the discretion to skip treatment to reduce out-of-pocket payments, and this will impact the success of their treatment and may cost both the patient and the government more in the long term. So can MOH reconsider how prudent it still is to restrict the use of MediSave in these public healthcare institutions?
Mr. Chairman, I thank the member for asking the clarifications. Yes, indeed, for PCHI, it is based on residents with the same household address, so that we know that they are actually staying in close proximity and they can actually mutually support each other. But in terms of MediSave usage for mutual support, in fact, actually, you can actually designate a next of kin, for example, where you have your spouse or even the children who's not necessarily staying within the same address can also add support with their MediSave to contribute to the care of their aged parents who may not reside in the same address, but they can actually use the MediSave from their children and vice versa. In terms of liberalizing MediSave usage, actually we have through the years allow more and more users for MediSave. You will remember that when we first started with the CDMP, there were only a few conditions that were in it, and in the last few years, more and more conditions were added, with considerations such as disease prevalence, whether there are effective treatment, and whether there is clear treatment protocol that can translate to a good outcome. So we are open to review the list of disease that will be added on over time as the science and the medical understanding develops as well, and in consultation with a panel of medical experts who can advise us on what they feel is useful to include in the CDMP list. And we are always opening, further opportunities to use MediSave. And as the member pointed out, there could well be situations in which we could liberalize some more, and we will continue to do so.
We've got time for just two more clarifications, so could I invite members to keep them short? Mr. Yip Hon Weng.
Thank you, Chairman. I'm glad to hear from Minister Masagos that the Ministry is reviewing the Senior Mobility and Enabling Fund. Can the Ministry provide more details about the focus area of review and when will the review be completed? Thank you.
We thank the member for the clarification. We will begin the review this year, hopefully by the second half, but we do not know yet the scope nor the time that this will complete.
Last clarification, Mr. Lewis Ng.
Thank you, sir. I thank PALSEC for the reply on the IVF policies. There's quite a fair bit of good suggestions out there on IVF, and that's why I filed so many CATs, PQs, German motions. So could I ask whether MOH can consider setting up a citizen work group to really deep dive into this issue of IVF here in Singapore?
I thank member for the suggestion. I'm sure that this is something we can consider, and I'll follow up with the member after this budget debates and COS debates are over. Thank you.
Chairman, excuse me, Chairman. My clarification on the pricing of the public health services have not been answered.
I'm afraid, Mr. Leong, it's 5:50 p.m., which is the guillotine time for this head. So, Dr. Tan Wu Meng, if you'd like to withdraw your amendment. Or Minister?
Perhaps I can just give a very quick answer. First, we take into account all the costs that healthcare institutions incurred, because someone has to pay for these costs, whether it's the government, whether it's the patient, whether it's the institution. So we have to cost them fully. By having costed them fully, the government provides subvention to cover the bulk of the cost of operation and the cost of investment of the building of this infrastructure. And on top of that, we provide subvention for the patients when they go and see the doctors or they receive treatment at these healthcare institutions. So yes, we account for the cost of the building and the delivery of services. But at the same time, we provide subvention and subsidies for the patients and for the institution's operation.
Dr. Tan Wu Meng.
Mr. Chairman, I thank all members for their cuts, and I thank our ministers, senior ministers of state, parliamentary secretary at MOH for their responses and sharing. The COVID-19 virus doesn't sleep, it does not rest. And so our healthcare frontliners, our agencies, our MOH officials have also had many sleepless nights because of this COVID pandemic, presumably with implications for sleep health, as Parliamentary Secretary shared earlier. So a big thank you to all who keep us safe, and in doing so, keep Singapore going. I beg leave to withdraw my amendment.
Is the honourable member given leave to withdraw the amendment? I think leave of the majority is given. The amendment is withdrawn. We go to the main estimates. The question is that the sum of $17,355,401,300 for head O stand part of the main estimates. As many as are of their opinion say aye. To the contrary, say no. I think the ayes have it. The ayes have it. Next, the development estimates. The question is that the sum of $1,489,629,300 for head O stand part of the development estimates. As many as are of that opinion say aye. To the contrary, say no. I think the ayes have it. The ayes have it.